When we talk about heart failure, we're describing a condition where the heart simply can't keep up with the body's demands. It's like an overworked engine that just can't deliver enough fuel to keep everything running. And this breakdown can happen in two major ways. Either the heart isn't pumping with enough strength, or it's not filling up with enough blood to begin with. The first case is known as systolic heart failure. The second, diastolic heart failure. In both situations, blood that should be moving efficiently through the heart and out to the rest of the body starts to back up often into the lungs. That backup leads to congestion, fluid buildup, and the name we often hear, congestive heart failure, CHF. This condition affects millions of people worldwide, and left untreated, it can be life-threatening because the body simply isn't getting what it needs to survive. One of the reasons CHF is so common is that many different heart conditions can lead to it. Diseases like coronary artery disease or problems with the heart valves can gradually chip away at the heart's ability to function. Over time, that wear and tear builds up until the heart starts to fail. To understand this more clearly, think of the heart as a pump that has to move a certain volume of blood every minute, what we call cardiac output. This output is the result of how fast the heart beats, multiplied by how much blood it pushes out with each beat. That second part, the amount pushed out, is called stroke volume. Let's say the heart beats 70 times per minute, and each time it pushes out 70 milliliters of blood. That gives us 4,900 milliliters per minute, nearly 5 liters of blood circulating every minute. But here's the thing, not all the blood in the ventricle gets pushed out. If 70 milliliter leaves the ventricle during each beat, but the ventricle actually had 110 milliliter in it to begin with, that means 40 milliliter was left behind. This gives us what's called an ejection fraction, the proportion of blood pushed out compared to how much was in the chamber to begin with. In this example, 70 out of 110 gives you about 64%, which is considered normal. Anything between 50 and 70% is typically fine. But once the ejection fraction drops to 40% or below, that tells us the heart isn't squeezing hard enough. That's systolic heart failure. Now, on the flip side, diastolic heart failure happens when the heart muscle still contracts well, but just isn't filling with enough blood. Imagine trying to throw a ball far, but you never get a good grip on it to begin with. The force is there, but the volume is low. In this case, both the total blood in the ventricle and the amount pushed out are low. But if you divide those two small numbers, you still get a normal looking ejection fraction. So even though the percentage looks fine, the actual volume delivered to the body is reduced, and that's the core problem with diastolic heart failure. A key factor here is something called preload, which refers to how much blood is in the heart just before it contracts. The more the heart fills, the more it stretches, and the stronger it contracts up to a point. This principle, known as the Frank-Starling mechanism, is like stretching a rubber band before snapping it. The farther you stretch it, the more powerful the recoil. Only with the heart, it's active muscle contraction, not just passive recoil. Heart failure doesn't discriminate between sides of the heart. The right ventricle, the left ventricle, or both can be affected. This gives us terms like right-sided heart failure, left-sided heart failure, or biventricular failure when both are involved. And both sides can have systolic or diastolic dysfunction. Since the heart works in a series, a problem on one side often impacts the other. For example, if the left side isn't pumping well, it can create pressure that makes it harder for the right side to push blood into the lungs. In many cases, what starts as left-sided failure eventually turns into failure on both sides. Left-sided systolic failure is the most common form and is often triggered by damage to the heart muscle, what we call the myocardium. This kind of damage is frequently caused by coronary artery disease, where plaque builds up in the artery supplying the heart itself. When these arteries narrow, less blood and oxygen reach the heart tissue, weakening it. If an artery becomes completely blocked, a heart attack can occur, leaving behind scar tissue that doesn't contract at all. That scarred area weakens the overall force of contraction, reducing how much blood the heart can pump with each beat. Another frequent culprit is chronic high blood pressure. When pressure in the arteries is consistently high, the left ventricle has to work harder to push blood against that resistance. Over time, the muscle thickens in response, just like any muscle under strain. This thickening or hypertrophy can initially help, but as the muscle grows, it needs more oxygen, and the coronary arteries, now compressed by the expanding muscle, can't always deliver it. The imbalance between oxygen supply and demand weakens the muscle's ability to contract, contributing to systolic failure. Some hearts react differently, not by thickening, but by stretching. In a condition known as dilated cardiomyopathy, the heart chamber enlarges in an effort to hold more blood and increase output. This stretching uses the Frank-Starling mechanism to temporarily improve contraction, but over time the muscle becomes too thin and weak to pump effectively, leading again to systolic heart failure. The heart becomes like a balloon that's been inflated too many times, flimsy and inefficient. Diastolic failure, on the other hand, often involves hearts that are too stiff. Remember the thickened muscle from hypertension? That muscle can eventually intrude into the chamber space, leaving less room for blood to enter in the first place. Other causes of diastolic failure include aortic stenosis, where a narrowing of the aortic valve limits blood flow, and hypertrophic cardiomyopathy, a genetic condition where the heart walls thicken abnormally. Restrictive cardiomyopathies, where the muscle becomes stiff and unyielding, also limit how well the heart fills. In all these scenarios, the result is the same. The chamber doesn't stretch enough, doesn't fill enough, and doesn't pump out enough, even if it's contracting well. When the heart struggles to meet the body's needs, the body tries to help sometimes in ways that backfire. Less blood flow to the kidneys activates a cascade of hormones meant to conserve water and salt, increasing blood volume. Initially, this helps fill the heart more and improve output through the Frank-Starling effect. But over time, the excess fluid overwhelms the system, leaking into tissues and worsening congestion. This is where the hallmark signs of CHF appear. Blood backs up into the lungs, pressure in the pulmonary vessels increases, fluid begins to seep out of the capillaries and into the air spaces of the lungs, causing pulmonary edema. Breathing becomes difficult. Patients feel short of breath, especially when lying flat, a symptom known as orthopnea. They may wake at night gasping for air, needing to sit upright just to breathe. Doctors listening to the lungs may hear crackles, tiny sounds, as air moves through fluid-filled spaces. In severe cases, capillaries in the lungs rupture and blood seeps into the alveoli. White blood cells, called macrophages, engulf the blood cells, becoming pigmented with iron and earning the nickname heart failure cells. Treatment for left-sided failure often involves medications that ease the heart's burden. ACE inhibitors can relax blood vessels, improving blood flow. Diuretics help rid the body of excess fluid, reducing pressure in both the heart and lungs. Right-sided heart failure is often the result of left-sided failure. As pressure builds in the pulmonary circulation, the right ventricle has to work harder to push blood into the lungs. This strain leads to right ventricular failure, completing the cycle and leading to what's known as biventricular heart failure. But right-sided failure can also happen on its own. Conditions like congenital heart defects that cause left to right blood flow, such as atrial or ventricular septal defects, can increase the volume in the right side of the heart, leading to muscle thickening, reduced compliance, and eventually failure. Chronic lung diseases are another common cause. When the lungs can't exchange oxygen properly, blood vessels in the lungs constrict in response. This raises pressure in the pulmonary arteries, making it harder for the right side of the heart to do its job. When lung disease causes this kind of heart failure, it's known as cor pulmonale. With right-sided failure, blood backs up not into the lungs, but into the rest of the body. One of the most visible signs is jugular venous distension, the bulging of the neck veins as blood pools in the upper body. Organs like the liver and spleen swell with fluid, causing discomfort. Long-term liver congestion can lead to scarring and ultimately liver failure known as cardiac cirrhosis. Fluid can also accumulate in the abdominal cavity, leading to ascites, or in the lower limbs, causing swelling known as pitting edema. When gravity pulls fluid into the legs or the sacrum, pressure leaves lasting impressions. Just like with left-sided failure, treatment includes medications to reduce fluid overload and ease the strain on the heart. In severe cases where the heart rhythm is disrupted or uncoordinated, pacemakers can help resynchronize contractions. Some patients may require mechanical pumps, ventricular assist devices to support the heart's function, and when all else fails, a heart transplant may be the final option. Heart failure is a complex condition, but it often begins with subtle changes. Understanding how the heart fails and how it tries to adapt helps us recognize it earlier, treat it more effectively, and give people a better chance at living a longer, healthier life, step by step, beat by beat.